Does high LDL cholesterol increase your risk of heart attack, stroke, and or death? Have you been misled? And the reason I put that there is because if you've grown up in the Western world, you have been misled by pharmaceutical commercials because what they teach us, which we've covered multiple times, is that your risk of death and its relationship to cholesterol is linear. That's what the commercials all say. That's what the cardiology organizations say. Everyone says that. But if you dive into the research, and my forthcoming second book is on this entire topic. If you dive into the research, the graph does not look like that. The graph actually looks like this. And so what that means is there is a too high level and there is a too low level, but there's also a sweet spot. And so knowing what the too low level is can keep you from going too low because if you go too low in cholesterol, your risk of type 2 diabetes and breast cancer and all cause mortality goes up. But also, if you go too high above a certain level, all those things increase as well. So it benefits the powers that be for us to be brainwashed that it's linear because if it's linear, then anything above the level they say is safe, they get to prescribe a statin for, and that's recurring income forever for all the people that are on those drugs. And those are one of the best-selling drug classes in the history of pharmaceuticals. So there's some conflict of interest there. But you can read the book to get all the nitty-gritty on that, and we've covered various pieces of it through time on this channel. But what I want to focus on today is LDL specifically, which stands for low density lipoprotein, or the quote unquote bad cholesterol, is how most people refer to it. I want you to learn that LDL is not bad and HDL, the other one, is not good. A better metaphor for them is exports for LDL and imports for HDL. Why? Well, LDL is exported from the liver to go out to the body to help patch drywall, metaphorically. When you damage any tissue, the LDL is there to help patch that tissue and heal it. And in the opposite way, HDL is the imports. HDL takes the cholesterol once the handyman is done patching your drywall, the HDL is taking the remaining materials and returning them to headquarters or returning them to the liver to be reused and recycled. So again, the most commonly accepted dogma is that high LDL will increase your risk of heart attack, stroke, and death. But we're going to look at research today from the Journal of the American Medical Association that suggests otherwise. So let's dive into that. And this is the paper here that was published in 2022, again, in the Journal of the American Medical Association, Cardiology. And the title of the paper is Association of Coronary Plaque with LDL Levels and Rates of Cardiovascular Disease Events in Symptomatic Adults. So what this paper is looking at, you can gain down here. So the importance of this paper, why is it important? Well, because atherosclerosis is the disease process behind heart attacks and stroke. Heart attacks or cardiovascular disease is the number one killer worldwide. And so understanding risk factors for the number one killer is very important for the largest amount of people, right? And so they say down here, atherosclerosis burden and coronary artery calcium are associated with the risk for atherosclerotic cardiovascular disease events, with absence of plaque and coronary artery calcium indicating low risk. Is this true in patients with high LDL? That's not known. So what they wanted to find out in this study is if we look at patients with high LDL, what is the relationship between high LDL and cardiovascular disease event risk? And so the primary outcome, as you can see down here of this study, is they want to see how many heart attacks, strokes, or deaths happen in their population of over 23,000 people that are symptomatic for um, cardiovascular disease. Okay. And so What they're looking at is they divided LDL levels up into five different levels. There's less than 77, which, if you read cardiovascular disease consensus statements from, say, the European Society of Cardiovascular Disease or all these other organizations, American Heart Association, et cetera, they say in high risk individuals, you want to have your LDL below 77. For secondary prevention, you want it below 77. What is secondary prevention? That's people who have already had a heart attack or stroke, and they want it down below 77 to prevent the second one. So that's the lowest group. The next group would be 77 to 112, 113 to 154, which, if you look at your labs, anything over 100 is going to be marked lab high. 155 to 89, and then the highest group, 190 and above. And so what they did was they looked at people's LDL levels, and then they compared those to the same people's um, coronary CT scans. So coronary CT angiography, where they inject iodine contrast into your arteries to observe for um, uh, 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 stenosis of the arteries of the heart, or narrowing of the arteries of the heart, or blockage. So the contrast helps them see that. But the coronary CT angiography machine can also run a coronary artery calcium score, which, looking at the calcium levels in the arteries of your heart, helps us understand calcified plaques. And so this paper was looking at over 23,000 individuals, as we'll see, stratifying them by their LDL level and then also by their coronary artery calcium score, and saying, is there a connection amongst it all? So let's go over to the paper and see what they found. Okay, so here we are on the PDF of the paper. And if we look at this, okay, what was this study consisted of? Again, if we just review what's the main question the authors were seeking to answer, is how common are plaques in the arteries of the heart, and is it associated with the rate of cardiovascular events in patients with very high LDL levels? Okay. Why is this important? Well, there's not really any studies on big populations with high LDL. Okay. So most of the studies are extrapolating results to say, okay, well, if someone has very high LDL levels, they're going to have higher heart disease and stroke risk. People with levels 190 and higher are, again, universally considered to be at higher risk of heart disease and stroke. But is that true? That's what this paper is asking. This is the largest paper or largest study ever done on a population of people that are symptomatic and have very high LDL. So this is the kind of best paper we have so far. So what they did was they took 23,000 people from Denmark, average age 58 years old, and they said, what are their LDL levels and how does that relate to the coronary artery calcium scores? And so let's dive in. So again, we've talked about before, high levels of LDL are associated with or assumed to increase your risk. And so this study had two goals. The first was to describe in a large, carefully um, determined cohort of symptomatic patients undergoing coronary CT angiographies. They want to know what's the prevalence of calcified plaques and non-calcified plaques. Now, why is that important? Well, calcified plaques in the heart, in the arteries of the heart, tell you there's atherosclerosis there, and it's been there for a while because there's been calcium laid down. Plaques that are calcified are older. They've been there long enough for the body to lay down calcium and minerals to try and stabilize those plaques and prevent rupture. It doesn't mean they can't rupture, but the calcification helps decrease the chance of rupture. Non-calcified plaques, as we've talked about recently in relation to, in my office, I had cardio risk come in and run coronary intima media ultrasounds, intima media thickness ultrasounds on patients. Why? Well, because the ultrasound can see plaques that are not calcified. Non-calcified plaques are not seen on the coronary calcium score. They can be indirectly seen, represented by stenosis of your arteries on the angiography, but the best way to see them and measure them is through the carotid intima media thickness ultrasound, which is non-invasive, doesn't require radiation like a CT, doesn't require contrast like the angiography. And non-calcified plaques, again, are newer plaques and they haven't been calcified yet, so they're not as stable. So they're at greater risk of rupturing. So the first goal was to look at how common are calcified and non-calcified plaques in a symptomatic population of patients. And the second goal is to describe the relationship of the LDL levels of those patients to the plaques and the associated risk. So that's what they did. And just so you know, if people who are trying to be in this study, so over 23,000 people were in this study, exclusion criteria are important in any study, and this study excluded people that had known coronary artery disease at the time of their coronary scan. So that would be either previous heart attack or previous coronary revascularization. They categorized the coronary artery disease plaques into non-calcified and calcified, as we said. Severity of the disease was categorized according to presence or absence of obstructive disease, as well as based on the coronary calcium score. So the score of 0 is ideal. The next best is 1 to 99, and then the group considered the highest risk was greater than 100 on the coronary calcium score. As far as the angiography, they classified the presence of obstructive disease defined as no coronary artery disease, so zero blockage of the artery and absence of any plaque. Then the next group was non-obstructive coronary artery disease, so they had some plaque and less than 50% blockage. And then obstructive disease was greater than 50% blockage in the arteries based on the angiography. So the prevalence of coronary calcium score of 0 differed across LDL, being lowest in patients with LDL of 190 and highest in patients with LDL 77 to 112 and 113 to 154. So that's very counterintuitive, right? Because we started off today saying, hey, we're taught that the higher your LDL, the higher your risk of death from all causes. However, in this group, the people with the highest LDL had the most zeros on their coronary calcium score. That's paradoxical, right? And the people closer to the normal, quote unquote, normal range of LDL that your doctor wants you to have, they had less zeros on their coronary calcium score. They had more positives. So interesting. In all LDL groups, a coronary calcium score of 0 is associated with no coronary plaque in most patients with LDL levels of 190. So here's where the disconnect is. You go to your doctor, you have your LDL run. If it's lab high, they're telling you you're at greater risk. You need a statin drug, or you're going to die, right? Well, this is saying, hey, 77% of people with LDL greater than 190, 77% of them had a coronary calcium score of 0. So they're being feared into using a drug when their actual risk is not greater. So that means the drug becomes nearly 100% risk because there's no benefit they can gain because they weren't at risk to begin with. And what else can we learn from that? We can learn that there are many more factors besides LDL in determining your risk of heart attack or stroke. LDL is just one factor, and it's called a weak factor. It has a weak association. So there's many other factors that influence your risk of heart disease or stroke. So the authors conclude 4 key points emerge from our analyses. First, atherosclerotic burden is heterogeneous or mixed across a spectrum of LDL levels, and risk is consistently associated with plaque burden. Okay, so high LDL does not mean high risk. High LDL plus high plaque burden means high risk, or even low LDL plus high plaque burden means higher risk. So your risk is really more strongly associated with your plaque burden than it is your LDL level. And that's why in my office, we have you run coronary calcium scores or get carotid intima media thickness ultrasounds to look at markers that really matter, right? We run the LDL to see, you know, um, see if it's high or not, because many things raise it independent of heart disease, like low thyroid or trauma, injury, inflammation for many other reasons. But in regards to cardiovascular risk, your plaque burden is a more strong risk factor than your LDL. And so you want to run tests that actually look at that. And that is things like coronary artery calcium score, coronary angiography, carotid intima media thickness ultrasound. Second, we observed absence of plaque in 46.2% of patients with LDL levels of at least 190. So again, mainstream media would say if your LDL is 190, you are a walking dead. But these guys in the largest study ever done on a population with cholesterol this high said nearly half of them had absence of plaque. So again, to say your high cholesterol means you have atherosclerosis and you're going to die is not scientifically supported. Third, coronary CT angiography ascertained absence of coronary artery calcium, indicated no detectable plaque in 86.8% of patients, including those with LDL-C levels greater than 190. So this is a test that we can use to help stratify patients at risk. Lastly, absence of plaque and coronary artery calcium was associated with low event rates across all LDL levels, even when non-obstructive, non-calcified plaques were present. Okay, so um, it's all about the plaque burden, not your LDL level. So taken together, our results support the use of coronary CT angiography results for risk stratification, including de-risking of symptomatic patients with high LDL levels. So risk stratification is, hey, we have 10 people with symptoms and various LDL levels. The coronary CT angiography will help us determine who we should treat first, who's at the greatest risk, and it'll help us de-risk of those 10 people. It'll also help us say, hey, you don't need to worry at all. You don't need drugs. You're fine. Okay. This is important because such individuals are universally considered to be at high risk with very low LDL-C goals that can only be achieved by treatment with statins and other therapies like PCSK9 inhibitors. So, among the large proportion of patients with LDL levels of at least 190 who have no plaques, the net benefit of such intense treatment is questionable. So, again, it helps us de-risk those people, not put them on drugs they don't need. When you don't need a drug, the only thing the drug can do is hurt you. Okay. And statins hurt a lot of people, even people that need them. So we don't need to be prescribing them to people that don't need them. So I hope this was informative for you. Um, another couple statements. They said our data show that absence of atherosclerotic plaque and coronary artery calcium in middle-aged symptomatic patients with high LDL is a common finding associated with low risk. Okay, so again, if you have high LDL but low plaque load and low coronary calcium, then you have low risk. Even if non-obstructive, non-calcified plaque was present, absence of coronary artery calcium was associated with low event rates. So we want to get the full picture. The more data we have, the better we can stratify each patient. Okay. However, in individuals with obstructive non-calcified coronary artery disease, the event rate was substantially higher. So again, that's saying what we said regarding the ultrasound. If you have obstruction of your arteries from a plaque that isn't calcified, that plaque is most likely to rupture. So those people are at higher risk, and we need to take action with those people. Thus, if there's no obstructive coronary artery disease present on the coronary angiography, the simple quantification of coronary artery calcium can identify patients at low risk, even if they have high LDL. So, thus, the results may be used primarily to withhold additional novel and expensive therapies to lower cholesterol in people with calcium scores of 0 who would have derived limited absolute benefit from the drug. So, again, it allows us to de-risk and not put you on drugs that you don't need. So, this is very important because, again, this is the first study of its kind done on such a large population of high LDL. And again, the final conclusions are that This study suggests among symptomatic patients with high LDL who are considered universally at a high risk by the mainstream media, that if they have absence of calcified and non-calcified calcified coronary plaque, then they're at very low event risk rate and they don't need the medication. These results highlight the multifactorial character of atherosclerosis as a disease that is not only driven by LDL. So again, they say there, we need to look at the context of the entire patient, the individual. Yes, LDL might be contributing, but what's their plaque burden? What's their stress levels? What's their sleep? What's their diet? What's their physical activity? Your risk for heart disease is far more than just your LDL level. Do you smoke? Are you obese? Are you lonely? All these things matter more than your LDL level. So if you're out there and you've historically had high LDL and high total cholesterol, it doesn't mean that you're damned to a statin drug or a PCSK9 inhibitor. It doesn't mean that you're damned to heart disease, stroke, or early death. You need to be stratified by, don't just reflexively be treated because your LDL is high. If a doctor just sees your LDL level and is trying to give you a statin drug, they are a statin drug vending machine. They are not thinking critically or clinically enough. If you have a high LDL, well, then the next step would be, and you're having symptoms, the next step would be, well, let's get a coronary artery calcium score, let's get a coronary angiography, and or a carotid intima media thickness ultrasound, which is the least invasive of those three tests. And that would help stratify you further and help us know, hey, does this person have a plaque burden? If not, then their high LDL doesn't put them at increased risk. They don't need to be on another medication.